Hello, everybody. Thanks so much for coming to our Lunch and Learn about updates on nutrition for bone health. The three of us are going to be speaking, and we're going to ask that you save all questions for the end. We will be monitoring the chat throughout, but we'll be addressing questions at the end. I'm Melinda Wu. I'm a pediatric endocrinologist at Johns Hopkins University. And so let's start. The three of us have no relationships to disclose that are related to this presentation. And in this talk, we're going to do an overview of cystic fibrosis-related bone disease, which is abbreviated CFBD throughout this talk. We're going to talk about how to screen for bone disease, how to prevent it, particularly focusing on why you're all here, which is optimal nutrition. We're also going to emphasize the importance of exercise and wrap it up with how to treat CF bone disease. So what is CF bone disease? It is skeletal fragility. We know that people with cystic fibrosis are at an increased risk for fractures compared to the healthy population. So in young adult women with cystic fibrosis, this study found that they had a 100-fold increased risk for vertebral fracture compared to healthy controls without cystic fibrosis. Rib and vertebral fractures can have important sequelae for people with cystic fibrosis, including pain, ineffective cough, ineffective airway clearance, kyphosis, chest wall deformity, and reduced lung volume. We measure and screen for CF bone disease with a DEXA scan, abbreviated DXA. People with cystic fibrosis have low bone mineral density as measured by the DEXA. How do we define osteoporosis in people with cystic fibrosis? Many of you may be aware of a T as in Thomas, score less than minus 2.5 as the cutoff for osteoporosis. This is because in postmenopausal women, this T score is associated with fractures. But we're looking at people besides postmenopausal women, and so we use this criteria also for men who are over the age of 50. Or if these people have had a significant fracture history regardless of their T-score, so evidence of fragility fractures. But what about our young adults with cystic fibrosis? So for people who are less than 20 years old, i.e. children, premenopausal women, and men who are less than 50, we look at the Z-score, less than minus 2, plus a significant fracture history. The Z-score is comparing their bone density to people who are matched by age and sex, whereas the T-score is comparing to the peak bone mass that is expected to have been attained. And so for children, though, regardless of the bone density, if they have a pathologic fracture, such as a vertebral compression fracture, they should be considered as having osteoporosis and be treated. These are guidelines in the recent JCF review paper in 2019. So high-resolution peripheral quantitative CT is a method of imaging the bones. It is primarily a research technique, and it has been sometimes described as a virtual bone biopsy. And in these pictures, on the left, we can see a person with no cystic fibrosis. This is a healthy 23-year-old woman. And on the right, we can see a woman with cystic fibrosis of the same age. Now note, she does not have a diagnosis of CF bone disease, but just looking at these two pictures, you can see that there are already differences in the microarchitecture of the bones. The cortex is thinner. The trabeculae in the middle, that spongy bone, those connections are also thinner and more spaced out. So there are already differences even before we diagnose this using a DEXA. The prevalence of CF bone disease does increase with age, with this being first noted mostly in teenagerhood and increasing in adulthood. But this probably relates to the DEXA screening guidelines, which recommend universal screening at age 18 and only children at higher risk. So back to bone biology. The bone is a very active organ, and there is ongoing resorption and formation. This is mediated by osteoclasts, the bone cells responsible for breaking down bone, and osteoblasts, the bone cells responsible for depositing and forming bone. There are many factors that contribute to CF bone disease. And in people with cystic fibrosis, we know that there is an imbalance between how much formation and resorption is happening with a net loss of bone over time. Important factors include the use of glucocorticoids, chronic inflammation and infections, delayed puberty and hypogonadism, so sex steroid deficiency, insulin deficiency, or hyperglycemia, as seen in CF-related diabetes, or even before CFRD presents. CFTR dysfunction itself, as CFTR has been discovered in both those key cells, osteoblasts and osteoclasts. Malnutrition and the disconnect between the growth hormone and insulin like growth factor 1, as well as what we'll be focusing a lot of our talk on, which is nutrition, inadequate nutrition, and decreased physical activity. So bone accrual peaks in young adulthood, as I was mentioning with the T-score. We're looking at the peak bone mass attained by white women in their 20s, and that is set as the peak bone mass in the reference group when calculating a T-score. And so in healthy individuals, most of the bone accrual occurs during childhood, particularly during puberty. And sufficient estrogen for females and testosterone for males is necessary for this bone accrual. Women will have a rapid loss of bone mass during menopause, particularly in that first 6 months of becoming acutely hypogonadal. Now, people with cystic fibrosis can be seen as that lower third line, this suboptimal lifestyle factors, although cystic fibrosis is not really a lifestyle. This is their underlying disease. And so they have a lower peak bone mass that they attain, and so they are that much closer to being in a dangerous range for skeletal fragility. So how should we be screening for CF-related bone disease? We have very clear guidelines from both the Cystic Fibrosis Foundation, which were last updated in 2005, as well as the European guidelines in 2011, which are similar. So from the Cystic Fibrosis Foundation guidelines, universal screening is recommended for all adults, or in the European guidelines, this begins in childhood, somewhere 8 to 10 years. For children with cystic fibrosis who are at least 8 years, the CF Foundation guidelines do recommend screening with a baseline DEXA scan if they are at risk for having CF bone disease. So being undernourished, having a low FEV1, chronic use of high-dose glucocorticoids, having delayed puberty, or having a history of fractures. So what should you do once you have that baseline DEXA? There are follow-up guidelines from the CF Foundation and the European guidelines. If there is low bone density for age, so that is a Z-score less than or equal to -2, then the CF Foundation guidelines recommend that you do your next DEXA in 1 year, and the European guidelines agree on that. The European guidelines also highlight that if they have a history of a low trauma fracture, they should be getting an annual DEXA, because at the heart of it, CF bone disease is about skeletal fragility. It's not actually about that measured bone density. And so normal bone density technically is a Z-score greater than -2, but for people with cystic fibrosis, we recognize a special section in which the Z-score is between -1 and -2, and we consider these people to be at risk for low bone density, although this is expert opinion. And in the CF Foundation guidelines, we recommend a follow-up DEXA in 2 to 4 years, while in the European guidelines, they are more specific and say 2 years. The CF Foundation guidelines also say that you can use a T or a Z score, but as we've previously discussed, T score is for people over 50 or postmenopausal women. And so in our young adults and children, we should be looking at that Z score, which is what is recommended in the European guidelines. So what pediatric sites should we look at? As a disclaimer, the CF Foundation guidelines do not actually talk about which site we should be looking at, and the European guidelines do, and the sites that they recommend are consistent with the International Society of Clinical Densitometry, i.e. the professional society of the people who do DEXAs. So for pediatrics, that's the lumbar spine, so L1 through L4. And the total body less head. So they do a total body scan, and they just don't include the skull when measuring their calculation. This is also sometimes called a whole body less head or a subtotal. In the adult population, it is lumbar spine again, as well as the hip. Now, one of the caveats to know when you're getting your DEXA scan is that the DEXA can underestimate bone mineral density in short children. Those previous images, I confess, are not from a person with cystic fibrosis, but this growth chart is a person with cystic fibrosis and extreme short stature. Most of our patients aren't this short. And so her DEXA shows markedly low bone density, particularly at the total body less head, with a Z-score less than -3.2. But when adjusting for her short height, she actually has normal bone mineral density for age, with her total body less head Z-score being -0.8 and the lumbar spine being 0.4. And so both of these are normal bone density. And thus, for this patient, we recommend that her next DEXA should be in 5 years. There are low rates of screening for CF bone disease, and this is only looking from the CF Foundation patient registry data for adults, because that's where universal screening should be happening. And the median is 60%. Of adults at CF centers are getting a DEXA screening at least once every 5 years. This is also true at my center, Johns Hopkins, where 65% of adults with cystic fibrosis who had not had a transplant over the course of 8 years had only had one DEXA. So how can we prevent CF bone disease? So this is focusing on the people with normal bone density, so the Z-score greater than -2. This does include that at-risk group of people between -1 and -2. And so it really focuses on optimizing the risk factors for developing CF bone disease: nutrition, exercise, aggressive treatment of pulmonary infections, minimizing glucocorticoid use, which is toxic to bones, and treating CF-related diabetes, delayed puberty, or hypogonadism if present in the person. So when assessing for delayed puberty, girls, we expect to have had breast development by age 13. We expect menarche to have occurred by age 16. And the treatment is estradiol and progesterone if it is found to be present. Talk with your local endocrinologist about prescribing this. For males, it's testicular enlargement by age 14, and the treatment for that is testosterone. So now I'm going to turn it over to Sarah.
All right, good time. Clear. All right, hi everybody. My name is Sarah Hendricks, and I'm the dietitian for the adult and pediatric centers at the Medical University of South Carolina in Charleston. And in the next 25 minutes or so, I'm going to do my best to review the evidence for key nutrition factors that are involved in bone health, both promoting bone mineralization and ones that promote bone resorption. We'll talk about optimal doses of these nutrients where available, and then some foundation foods that provide good sources of these nutrients. So low bone mineral density is significantly associated with low BMI in those patients with, low BMD is associated with low BMI, and also in patients with normal weight with low lean mass. So, and one of those reasons may be the reduced insulin-like growth factor in those patients. That's seen commonly in malnutrition. And IGF-1 is involved in protein anabolism and osteoblast proliferation and differentiation. So maintenance of healthy weight and lean body mass is important for bone health and relies on adequate protein calorie intake and appropriate PERT dose, as well as physical activity, which we'll talk about more soon. So protein is an important but often undervalued nutrient in bone health. Adequate protein intake is needed for bone accrual during childhood and adolescence and maintenance through older age. And about 1/3 of bone's mass is composed of proteins, mostly as collagen, and that's shown by the blue in the pie chart. The remainder of bone composition is hydroxyapatite, which is this matrix of calcium and phosphate, and then you've got 10% as water. And there are multiple mechanisms through which protein may be protective of bone. So adequate protein is essential to stimulate the activity of anabolic hormones and growth factors that have essential roles in the regulation of bone mass. And protein intake may indirectly influence bone through its impact on lean muscle mass, through increased mechanical loading. And then dietary protein intake increases calcium absorption. And low muscle mass is associated with bone mineral loss as well as other poor outcomes in CF. An adequate protein intake is necessary to prevent that loss of lean muscle mass. And although we know that fat malabsorption is a big concern in CF and EPI, protein digestion is also impaired. And so one study found that protein digestibility was only 47% compared with healthy subjects in both children and adults with CF and EPI not taking enzymes. And so I think this is important to consider, especially for our patients who are self-adjusting PERT doses in the setting of modulators and weight gain. We need to make sure that they're optimizing protein. And so if that's the case, then repeating a fecal elastase is crucial there. And so I have the RDAs for protein mostly for reference for you. But what you should know here is that these values were created based on, largely nitrogen studies and show minimal intakes of protein needed to prevent deficiency, also in the setting of minimal physical activity. So the recommended protein intake in CF is about 1.5 to 2 times the RDA for age, and this is in line with general recommendations for bone health as well. And I couldn't find any studies specifically looking at protein intake on bone health in CF, but in the general population, a meta-analysis supports that protein intake above the RDA is beneficial to bone health at several sites for adults. They did not find any significant difference between animal and plant protein, although the data was scarce in this study. And these were not super high intakes of protein either, so patients with over 2.5 grams per kg were excluded from this study. And then in prepubertal boys, protein intakes above the RDA enhanced the positive impact of physical activity on bone mineral content at several sites. And so moving on to calcium, this is the most abundant mineral in the body with 98% stored in bone. And most of the calcium in the body is in the form of hydroxyapatite, so it's that matrix of calcium and phosphate that I mentioned. And it's necessary for the rigidity, strength, and elasticity of our hard tissues. And calcium's vital to both bone accrual during skeletal growth during puberty, as well as maintenance of bone once growth is completed. And so calcium intake should be screened annually in CF, and we need to keep in mind that the CF-specific vitamins do not contain calcium. And calcium deficiency can occur for a number of reasons, some related to vitamin D deficiency, reduced calcium intake, poorly controlled malabsorption, so that the unabsorbed intestinal fat can bind calcium and you have increased losses through stool. And then there are certain drug interactions that can deplete or reduce calcium absorption. And then again here for reference, I have the CF guidelines for calcium intake that range from around 200 to 1,500 milligrams per day. And just a few words about calcium absorption from food. So there's an inverse relationship. The amount of calcium absorbed rises adaptively as intake is lowered. It also changes with age, so calcium absorption's higher in infancy and puberty and declines with age. And then bioavailability also varies by the type of food consumed. So absorption is about 30% from dairy products and other fortified foods, and almost twice as high in some of the green leafy vegetables. And then there's also some compounds in foods that can interfere with calcium absorption to be aware of. And so if your patient is not getting enough calcium-rich foods in their diet, supplements may be warranted. And the two most common forms of supplements are calcium carbonate and calcium citrate. So carbonate provides about 40% elemental calcium compared with 21% for citrate. And costs tend to be lower with the calcium carbonate, and compliance may be better since they need to take fewer pills. On the downside, calcium carbonate is more associated with GI side effects like constipation and bloating. And then calcium citrate's less dependent on stomach acid for absorption, so it can be taken without food and might be a better option for patients on PPIs or H2 inhibitors. And then absorption is best with doses of 500 milligrams or less. So if you have somebody taking more, you want to split those doses. Most of the calcium in the diet comes from dairy products. So some non-dairy natural calcium foods include canned sardines and salmon with the bone, some green vegetables. And then moving on to vitamin D, its main role is to assist with the intestinal uptake of calcium. So in the absence of vitamin D, about 10% of dietary calcium is absorbed, as opposed to 30 to 50% in a vitamin D replete state. And vitamin D levels below 30 nanograms per milliliter can lead to parathyroid stimulation, decreased intestinal calcium absorption, and induced bone resorption. So vitamin D deficiency and insufficiency are common in CF, and factors that contribute to deficiency include fat malabsorption, reduced sun exposure, treatment with steroids, impaired hydroxylation, non-adherence to regimens. So maintaining levels is essential here, and the recommendation is to monitor vitamin D levels annually, preferably at the end of winter when you can know the true low value, and then 3 months after a dose change. And then the CF Foundation recommends vitamin D levels be maintained above 30. And then again, for reference, I've got vitamin D intakes here. We have super helpful guidelines for the management of vitamin D in CF, starting with routine dosing by age and increasing based on serum levels and adherence. So this table is very abbreviated, but you can find the full guidelines at this reference that's on this slide. And very few foods naturally contain vitamin D. A few of those include oily fish, such as salmon and mackerel, cod liver oil, irradiated mushrooms, and egg yolk. And then fortified foods like milk and cereal provide some vitamin D. But the main source of vitamin D for most people is sunlight. There are several factors that can affect the synthesis in the skin from sun. That could be season, time of day, cloud cover, sunscreen, age. But in general, to get sufficient vitamin D synthesis through the skin for adults requires about 5 to 30 minutes of sunlight between 10 a.m. and 4 p.m. at least twice a week to the face, arms, hands, and legs without sunscreen. The American Academy of Pediatrics recommends against sunlight for vitamin D, so they want you to minimize UV light exposure to children. So in this case, supplements are probably warranted to keep levels adequate. So magnesium is another major mineral important for bone health. It plays major roles in mineral homeostasis. It influences hydroxyapatite crystal formation and growth. And it also induces osteoblast proliferation and is necessary for calcium and vitamin D metabolism. And although we don't routinely monitor magnesium in CF, serum magnesium is the most common and practical way to monitor status. However, only about 1% of total body magnesium is in serum, and so it's important to keep in mind that a normal serum magnesium level may not reflect true deficiency. So this is where dietary intake may come in helpful. So low magnesium levels in patients with CF are increasingly recognized and affects over half of patients with advanced CF lung disease. And the causes are likely multifactorial, include poor intake, poor absorption, poorly controlled diabetes. There are certain drugs with potential to cause renal magnesium wasting, such as aminoglycosides used to treat Pseudomonas, calcineurin inhibitors for transplant recipients. And I've got the RDAs listed here for reference. So they range from 30 milligrams to 420 milligrams a day based on age. Some of the best sources of magnesium in the diet are seeds, nuts, and beans. If you have a patient that is not meeting their dietary needs with magnesium, a supplement could be warranted. 200 milligrams of a chelated magnesium, such as citrate or lactate, has been found to be safe and effective. And remember that excess magnesium can lead to diarrhea, so be aware of that. And then for patients with very low levels, IV magnesium may be warranted. And then moving on to vitamin K. Vitamin K has 3 isoforms. So vitamin K1 is synthesized by plants and is the predominant form of vitamin K in the diet. Vitamin K2 is a bacterial byproduct and is mainly found in fermented foods and by animals that graze on grass. It has different chemical variants, with the most common being MK4 and MK7. MK4 is unique in that it's produced endogenously from the conversion of vitamin K1, and then MK7 and the other menaquinones are produced by intestinal bacteria. And then vitamin K3 is a synthetic compound found in supplements and in animal feed, and it's a provitamin that requires conversion to MK4 to be active. And then vitamin K has several roles in bone health. It improves osteoblast function, regulates bone mineralization, prevents soft tissue calcification, inhibits bone resorption. And there's emerging evidence that vitamin K2 in particular may play an important role in bone health, especially when combined with vitamin D3 supplementation. So vitamin K deficiency is common in patients with CF and has been attributed to fat malabsorption, long-term antibiotic use, and liver disease. And it's the least studied in terms of all the fat-soluble vitamins in terms of dosing and optimal methods for monitoring status. The CFF consensus guidelines recommend a low-dose supplementation of vitamin K for all ages daily. We don't have great serum monitoring. Serum vitamin K reflects recent intake and not stores. PIVKA2, or the undercarboxylated osteocalcin, is a sensitive indicator of early deficiency, but it's very expensive and not widely available. And so the most commonly used is prothrombin time, which is a non-specific indicator of deficiency, but just more often used. And so food sources of vitamin K1 include vegetables, especially the green leafy vegetables. And then natto is a traditional Japanese food made from fermented soybeans that has high amounts of vitamin K2 as MK7. And then there are two forms of vitamin A in the diet. So preformed vitamin A, retinol and retinol esters, and then provitamin A carotenoids. So the preformed vitamin A is found in foods from animal sources, and it's often added to foods like dairy and breakfast cereals. And then provitamin A carotenoids are plant pigments that the body converts to vitamin A in the intestine. So the main provitamin A carotenoids in the diet is beta-carotene and is found in brightly colored vegetables. And because vitamin A is fat soluble, the body stores excess amounts primarily in the liver, which can lead to toxicity. And beta-carotene is only converted to retinol if needed by the body, and the CF-specific vitamins are mostly beta-carotene. And the data on vitamin A and bone health is mixed. So most studies are done in postmenopausal women. And overall, there appears to be a benefit to bone health with beta-carotene intake and a potential negative effect with high intakes of preformed vitamin A, particularly when obesity and vitamin D deficiency are present. And some of the mechanisms by which vitamin A could affect bone health are that beta-carotene promotes osteogenesis and inhibits osteoclasts, while retinoic acid suppresses osteoblast activity and stimulates the formation of osteoclasts. And there's some evidence that preformed vitamin A may interfere with calcium absorption in response to vitamin D levels. So vitamin A deficiency is becoming less common in people with CF, especially in the setting of modulator therapy. But cases are most often associated with poor control of malabsorption or poor vitamin supplementation. It's recommended that vitamin A is monitored annually in CF, and a serum level below 20 micrograms per deciliter represents deficiency. Ideally, serum retinol is assessed in the fasting state, again, since recent intake can affect levels. And it's a negative acute phase reactant, so you want to avoid checking during acute illness to avoid false low levels. And then we also need to keep in mind that vitamin A is transported bound to retinol-binding protein, which is produced in the liver and often low in patients with liver disease and malnutrition. So assessing the molar ratio of retinol to retinol-binding protein in these patients can help guide the need for supplementation. And recommendations for vitamin A intake in CF are shown here in both international units and retinol activity equivalents. So retinol and beta-carotene have different bioavailability. So reporting vitamin A in retinol activity equivalents accounts for this difference in bioavailability. So that is shown in this little top box here. And then retinol activity equivalents can only be converted into IUs and vice versa if the sources of vitamin A are known. So I've got those conversions here in the box below. Foods from animal sources contain primarily preformed vitamin A, where plant-based foods contain provitamin A. And then vitamin C's protective effects on bone health could be through the suppression of osteoclast activity, its role in osteoblast differentiation, and the stimulation of collagen synthesis. And review studies show a positive correlation between dietary intake of vitamin C and bone density. So again, for reference, I have RDAs for vitamin C, which range from 40 milligrams a day for infants to 90 milligrams for adult males, and then additional 35 milligrams a day for smokers. And then these are just some of the common food sources of vitamin C. They tend to be in colorful fruits and vegetables. And then I thought silicon would be an interesting element to talk about because we don't hear much about it, but it is important for bone formation and maintenance. And It's been shown to improve bone matrix quality through its role in the formation of crosslinks between collagen and proteolycans. It facilitates bone mineralization and helps determine the strength, composition, and mechanical properties of bone. And it's the third most abundant trace mineral in the body after iron and zinc. And the most bioavailable form of silicon is orthosilicic acid, which is present only in liquids like mineral water and beer. Interesting. However, most other forms of silicon can be hydrolyzed to orthosilicic acid in the gut, and food is the main source in the diet. So natural levels of silicon in food are highest in plant-derived foods, and that's because plants take up and accumulate silicon from the soil. So the foods that acquire the most silicon from soil include cereals, grasses like rice, and then some herbs. And these are some of the top food sources of silicon in the diet. There's not enough evidence to establish an adequate intake, but based on extrapolations from the available data, 25 milligrams per day has been suggested to promote beneficial effects on bone in adults. And then boron is another element that we don't talk about a whole lot, but has a big role in bone health as well. So it has a beneficial impact on estrogen, testosterone, and vitamin D metabolism, which are all important for bone growth and turnover. And it enhances magnesium absorption and drives osteoblast activity. And again, there is not a recommended intake set for boron. There's an upper limit of 20 milligrams per day. But the World Health Organization estimates that an acceptable safe range is 1 to 13 milligrams per day for adults. And avocados are some of the best food sources of boron, followed by the prunus family. Legumes and brassica vegetables are also good sources. And the amount of boron in plant foods depends somewhat on the boron content of the soil and water where it's grown. And then interestingly, while coffee isn't a particularly high source of boron, it is a major source of the element for people in the US, just because we drink so much of it, probably especially on the last day of a multi-day conference. But then some other main sources in the diet are milk, apples, beans, and potatoes. And then one last nutrient that I wanted to touch on is phosphorus. So this is an essential nutrient and major component of hydroxyapatite in bones and teeth. And the majority of the body's phosphorus is found in bone mineral. Phosphorus deficiency results in rickets and stunted growth in children and osteomalacia in adults. But because phosphorus is so widespread in the diet, both naturally and from additives, most people don't have difficulty meeting needs for phosphorus, and deficiency is rare. But excess dietary phosphorus has been associated with adverse effects on bone and mineral metabolism. So this association may be in part due to the phosphoric acid content in cola drinks. And cola is a unique source of inorganic phosphate, which is readily and rapidly absorbed. And also, cola may displace milk in the diet. So, as I mentioned, phosphorus is in many foods naturally. Dairy is the largest contributor in the US. And the absorption rate from food is around 40 to 70%. And then phosphate additives are in many processed foods, and their absorption rate is even higher at the top end at 70%. And despite this long talk about different nutrients, the benefits to bone health with supplementation of individual nutrients don't hold up as well as dietary patterns. So there are a lot of nutrients that we didn't even have time to touch on: potassium, polyphenols, different herbs and spices that may have positive effects on bone too. But the key here is choosing whole foods, plants with high mineral and trace mineral contents, and getting outdoors and moving in the sun. And recent studies have shown that adherence to a Mediterranean diet is protective against osteoporosis. And I did make a handout with some simple and flexible bone healthy recipes, which I did not have time to share here, but I'll send those out on the listserv with the slides. And then I'm going to skip my summary slides since we're going to go over this as a group at the end, and I'll pass this on to Caroline.
Good afternoon. I'm Caroline Challoner. I'm a physical therapist in the Maine Medical Partners Pediatric Specialty Care Pediatric CF Clinic. And I'm going to give you sort of a down and dirty discussion about how exercise can complement nutrition in optimizing bone health. So brief outline, we're going to talk about general principles of exercise that are related to bone growth and the maintenance of bone health, and then go into that for the general population and then for patients with CF. And then not knowing how many PTs we might end up with in the audience and or how many people have a PT in their clinic, just some discussions about the role of physical therapy in promoting healthy bone density in these patients. So first, we're going to just quickly go over bone health and growth. Melinda touched on this earlier, but when we look at bone structure, we're looking at really two different types of bone that are contained in most of the long bones that we're talking about. So you have compact bone, which is under the periosteum, and in the diaphysis of long bones. That's your support and your protection. That's what withstands the compressive forces of the things that we do all day, every day. And then you've got spongy bone. It's also known as cancellous bone. That's got open spaces, and that shifts your weight distribution throughout the bone. So when we're talking about building bone, we're looking at how we're applying forces to both types of bone that you find. So Wolff's Law, taking us all the way back to PT school for some of us or undergrad, is saying that bones will adapt to the degree of mechanical loading that you apply to it. So that's why weight-bearing activity is emphasized so much in talking about bone health. If we decrease the stress on bones, we cause bone layers to weaken. So less activity means that we're not building as much bone. And the duration, magnitude, and rate of the force you apply to the bone, so for example, tendons pulling on their attachment, determines how we alter the bone. So it's not just about loading, it's about the type of loading that we're doing. Some of the principles of exercise that are related to bone that we're talking about here is that we're looking, kind of like we were talking about on the last slide, that optimal adaptation to bone strain, it requires sufficiently high magnitude, so it's got to be enough of a strain on the bone. It has to be an unusual distribution, so not something that's regular and consistent, and at a higher rate. So we're talking about exercises or activities that promote a ground reaction force that's above those during your daily activities. So as you can see in that picture over there, when you apply a force down on the ground, whether you're walking, running, jumping, or doing any of your activities, the ground gives a force back to you. And the higher ground reaction force that you create gives you a greater anabolic effect on the bone. But even moderate impact exercise can be associated with really significant improvements. So it doesn't always have to be this high intensity, high impact activity that can make a difference. Most successful intervention programs have been 2 or 3 sessions a week for 20 to 30 minutes. So it also doesn't need to be a huge time commitment to make a change in your bone growth. Again, going along with that, we see that there's a minimal force that you have to create to elicit an osteogenic response. So we're talking about overloading the tissues, which is what all 3 of these slides really have talked about, in order to create bone growth. And lean mass has a positive effect on bone mass because you have more muscle pull on your bones. So more and more of what we're going to talk about in some of these subsequent slides is how important resistance exercise, not just going for a run, is for building your bone density. So if we talk about exercise for bone health in the general population, I just wanted to give a brief. We're going to be talking about some levels of physical activity intensity and some different types of activities. So just as a quick run through, a lot of the research that's out there will look at your physical activity intensity and measuring it in terms of metabolic equivalence. So that's the energy it takes to sit quietly, like most of us are probably doing at this point in the day. And for the average adult, that's 1 calorie per 2.2 pounds of body weight per hour, or it's about 3.5 milliliters of oxygen consumed per kilogram per body weight per minute if you're thinking about a traditional kind of exercise test. One limitation of measuring activity in this way is that it doesn't consider the fact that some people have a higher level of fitness than others. So some of these activities may be for some people, more moderate or vigorous than for others, but this is just one way that you'll see in a lot of the literature that they're measuring physical activity intensity. There are a number of other scales you can use as well. And then the other thing that a lot of the literature is going to talk about is high impact activity, and much of the focus is on plyometrics. So just as a review, plyometrics uses the stretch shortening cycle of your muscles. So you use a lengthening movement or an eccentric contraction of the muscle, quickly followed by a shortening or concentric contraction of the muscle, to sort of store and release energy in doing high impact activities. A caveat with plyometrics is this is not something that you can start out your patient who has not been exercising at all with doing box jumps. That's not going to go well for anybody involved. So you want to incorporate resistance training, flexibility training. You need an adequate base level of strength and flexibility to engage in some of these higher level activities. There's some examples of plyometrics down there at the bottom. But as you can see, they all involve some pretty significant jumping. And you need to know that your body mechanics are appropriate for that, or we're just putting them at risk for injury to other tissues. In general pediatrics, high physical activity is associated with high peak bone mass, and as has been discussed already, the pre and early peripubertal years are the ideal period for building bone mass. As Melinda talked about, normal peak bone mass is reached by about age 30. So what we're looking at is that weight-bearing activity significantly improves bone mineral content in prepubertal children. And that can be associated with gains over periods of 3 to 24 months of training. So there are varying levels of time in the research out there looking at trying to build bone mass in healthy children. And exercise also increases bone structural properties. So it's not just building the bone mass, it's building your bone area, your cortical thickness, and really setting that foundation for what comes later on in life. In adults in the general population, exercise programs, they typically recommend combining odd or high impact activity with high magnitude resistance training. So with adults, we're really looking at that resistance training, especially in premenopausal women. And the common decline in bone mass during aging that we reviewed earlier can be attenuated through exercise. And again, strength exercise has been highlighted in the research, as well as multimodal exercise programs. So there's no one exercise that's the best. We need to combine them all. So then if we get into recommendations that are out there in the literature for people with CF, the general recommendation is maintenance of normal BMI and lean body mass is important for bone health, as Sarah was reviewing earlier. So we're looking at moderate intensity intervention programs for skeletal development during growth and enhancing building of a stronger skeleton. And again, same as they are talking about in the general population, pre-puberty to early puberty is the best time to capitalize on these gains. The European and French guidelines, the CFF guidelines don't give any specific exercise recommendations. They talk about weight-bearing exercise when you're, looking at the grades based on the Z-scores that Melinda reviewed earlier. But the European and French guidelines recommend exercise 30 to 45 minutes 3 times a week, high-impact weight-bearing activity, but that for those who are not participating in regular exercise, low-impact activities can still be very, very useful. So I think this is something that we should consider as care teams, that it's about the change in exercise, not necessarily the intensity for everybody. In children with CF, as was reviewed earlier also, they have a high prevalence of fat-free mass deficit. So when we're talking about that means they have a fat-free mass index that's less than or equal to the 10th percentile. And you can have a hidden fat-free mass deficit where you have a normal BMI, but you still have less than the 10th percentile for your fat-free mass index. So that's telling us their BMI may be normal, but what is their body composition going along with that? And a lot of the talks here at conference have talked about using body composition more so than just what is that normal BMI to determine whether or not we need to make interventions in that realm. But fat-free mass deficit is associated with lower bone mineral density. So that tells us that that lean body mass, that strength training and resistance training is really important. In addition, the impact of regular weight-bearing exercise may be even more significant in children with CF than in healthy children because in general, although this is changing in the era of highly effective modulator therapy, children with CF are not typically as active as children in the general population. So the other thing we want to consider when we're doing exercise prescription for these patients is that, as we've talked about, exercise programs need to be of a sufficient magnitude to elicit a bone response. So, and they need to be specific to the patient. So it's got to be something that they want to do and something that they're going to enjoy. Not every patient is going to want to go out and do, plyometrics, but maybe they enjoy dancing and we can get them involved in something in some other way. So we want sufficient magnitude and we also want interest. And then a lot of the research out there suggests that it doesn't need to be an hour-long exercise program. It can be shorter, multiple sessions that actually appear to be more osteogenic than doing a long duration exercise session. And you want to have recovery periods in between exercise because that's going to enhance the bone adaptation. So we don't want them working out 7 days a week. They need some rest in there as well. The other thing we know about children with CF and children with pediatric chronic illness in general is that the functional muscle bone unit is affected, so you have decreased lean muscle mass because of reduced mobility, pubertal delay, as we've discussed, glucocorticoid exposure. So the muscle mass and strength increase during growth and puberty leads to an increased mechanical load on bone and a positive change in the dimension and strength in bone in these patients because of what we look at, kind of what they go through from a medical standpoint. Again, this study that is listed below recommended engaging in higher impact weight-bearing exercise at least 3 days a week. So we're seeing that 3 days a week come up repeatedly in the literature. And partnering with your dietitian in clinic to make sure if we're recommending increased activity, are we also recommending increases in their nutrient intake and their overall dietary health to support the exercise that we're recommending. And the goal here is that we're going to increase and help them achieve a normal peak bone mass in childhood so that we get more of that normal trajectory versus that lifestyle factor trajectory that was shown earlier where they're already coming in at a lower level. If we can get them at that normal level, we have a better chance of intervening. So the main takeaways for peds is that, again, pre-puberty and early puberty. So we want to be targeting exercise early. We want to be trying to focus on maintaining normal BMI with an emphasis on lean body mass. And again, for exercise prescription, moderate to high intensity, high impact weight-bearing activity, short bouts with adequate rest, and 3 times a week for 30 to 45 minutes. But remembering that for sedentary patients, any amount of exercise is going to be beneficial. When we go into talking about adults with CF, there's a couple of different realms that the research is looking at, one of which is osteoporosis. So exercise in adults can also have a positive impact on bone maintenance. What Melinda's actually going to talk about next is that exercise can be helpful in working with some of the pharmaceutical agents that we use to treat osteoporosis. So it's not just giving them a medication or giving them exercise, but kind of doing those two things together. The one caveat here is that if a patient does have diagnosed osteoporosis, you want to avoid any exercises that involve twisting or sudden movement because the last thing we want to do is cause a pathological fracture. And they should generally be lower impact activity for that population. But the research would suggest that in postmenopausal women with CF, walking, weight-bearing activity, and resistance activity are all effective for increasing bone density and preventing osteoporosis. The other thing to consider with your adult patients is that osteoporosis is a known complication of organ transplantation, so it's important to maintain normal bone density both before and after transplant to try to reduce their fracture risk. Another thing that we look at with adults, the same way that we look at it with peds, is that BMI obviously has a positive correlation with bone mineral density. So when we're looking at activity, we were looking at moderate and vigorous daily physical activity can help with how our bones are remodeling as we're aging and favor bone formation in those young adults as they're going into their adult years. So what we want to do is look at the average number of minutes of moderate daily physical activity, and that actually has a correlation with looking at their hip bone mineral density, which is one of the values that they recommend looking at for adults. And again, you see here, weight-bearing activity, peripheral strength training. So I know a lot of this seems really repetitive, but it is reassuring that a lot of the research is telling us the same thing, weight-bearing, but making sure we're also doing strength training. And one of these studies actually is suggesting that resistance training in adults is probably more effective at increasing bone mineral density in the femur than aerobic or respiratory fitness. So I think at least as PTs, we sort of have to get away from that thought of you build your bone density by going for a run, because it's not that it's not going to help you, but it might not be the most effective training strategy. And then the last thing for adults that they really talk about is exercise capacity. So, we talk about exercise capacity as a predictor of morbidity and mortality in CF. It's also a predictor of low bone mineral density. So making sure that you're looking at patients' exercise capacity is really important because exercise frequency and patients' performance on a 6-minute walk test both correlate with bone mineral density. So what we're really looking at if we want to get an accurate measurement of exercise capacity is a VO2 max, which is an independent predictor of bone mineral density and better than FEV1 or measures of pulmonary disease severity. So your VO2 max is the maximum amount of oxygen that an individual can utilize during intense or maximal exercise. It's usually measured in milliliters of oxygen per minute per kilogram of body weight, and it's typically done with a cardiopulmonary exercise test, and that could be maximal or submaximal. And I'm not in any way going to tell everybody exactly how you do a CPET, but if anybody in the room has done one, they are challenging to say the least. But basically what they do is they measure your oxygen uptake, your carbon dioxide production, and a ton of other ventilatory measures during a symptom-limited exercise test to truly determine where somebody maxes out. And that can give you a much better both predictive measure for yourself of, is this patient at risk for having low bone mineral density? Do we need to look into it more? And also help with your exercise prescription. The caveat to that is that getting patients in for CPETs is actually very challenging at most centers. They're used mostly for research, and a lot of places don't have access to them for regular exercise testing. So, main takeaways for adults: exercise frequency and exercise capacity both correlate with bone mineral density. VO2 max, as we've discussed, is an independent predictor of bone mineral density and is better than PFTs. So if we have the access to test for it, that would be the ideal. As compared to pediatrics, where we talk about moderate to high intensity, for adults, moderate intensity is probably the most ideal, and strength training may be more optimal than aerobic training in adults who already have low bone mineral density. And then the last thing I wanted to touch on really briefly is, when should you refer to a physical therapist? So physical therapists are known as being exercise specialists, and exercise prescription and recommendations is something that we all do on a regular basis. If your clinic has a physical therapist on your team, they should be doing an annual clinic evaluation, and some of the things that would be recommended in terms of looking at their bone mineral density is regular exercise testing. I've listed several out here. The first three are not kind of a formal CPET that's a 6-minute walk test, a 3-minute step test, or a modified shuttle walk test. Of the three of them, the shuttle walk test is the most challenging. If anybody remembers the beep test from middle school or high school gym, if anybody remembers it terribly, I'm right here with you. But those 4 tests can all be done in clinic. The first 3 are really field tests that are easier to use with less time or with less space. You also looking at strength testing, because clearly lean body mass is just as important. So you can use hand dynamometry. That's what's shown in the picture on the right there. And making recommendations for age-appropriate exercise based on the patient's interest and their physical capability. Also, what we do in our clinic is that PT can be involved with screening for the need for a DEXA scan along with the rest of the multidisciplinary team. So, in our clinic environment, I'm responsible for keeping track of if patients have been experiencing pathological fractures and flagging that as something that we need to be looking at more closely, as well as collaborating with your dietitian to ensure adequate nutrition to support what you're recommending. So none of this happens in a vacuum. We really need to be working with our multidisciplinary team to make the best recommendations, and then referring to outpatient PT as needed if a patient needs supervision for safe initiation of exercise, and that's not something you do in your clinic. If your clinic doesn't have a physical therapist, I'm always a fan of referring to outpatient PT, but that's my own bias. If a patient is flagged at being at risk for low bone mineral density and not doing any regular physical activity, if they've been diagnosed with osteopenia or osteoporosis on their DEXA, if they've had fragility fractures, or if they're sedentary at baseline and they want to initiate an exercise program, any of those reasons would be a great time to refer to an outpatient PT, because they're really going to be able to collaborate with your team on how best to move this patient's exercise forward in a safe, monitored way. And I'm going to turn it back over to Melinda.
All right, so we've really emphasized on how to prevent CF bone disease by maximizing our bone accrual through nutrition and physical activity. But when should we think about actual anti-osteoporosis medications? Whoops. Nope, sorry. There we go, okay. We should think about it when a person is at high risk for a future fracture. Fractures beget fractures, and so if they have a history of a pathological fracture, like a vertebral compression fracture, you should consider it. If they have a BMD-Z score less than -2, so they have low bone density and a history of a low trauma extremity fracture, or they are awaiting or have undergone a lung transplant or have chronic high-dose glucocorticoids, then they are at high risk for fracture. And so these are the people that we should really think about if they need treatment. The mainstay of treatment and what has been most studied in people with cystic fibrosis is bisphosphonates. This is a medication that will stop bone breakdown, so inhibiting the osteoclast activity. It is typically given as an intravenous infusions every 3 to 12 months. This depends on the specific medication as well as the age and pubertal stage of the patient. There is also an oral bisphosphonate formulation as well. What about modulators? So for ivacaftor, we have pretty equivocal data. As we recall, this was approved in the United States in 2012. And in a retrospective study of 7 patients treated with ivacaftor for 1 to 3 years, they did have a significant increase in their lumbar spine bone mineral density. But when looking at a prospective study of 26 people with cystic fibrosis who started ivacaftor matched to 26 people with cystic fibrosis who did not because they were ineligible for the modulator, and 26 healthy controls without CF, there were changes in the microarchitecture, but not bone mineral density. In a registry-based study looking at people in the cystic fibrosis registries of the United States and United Kingdom, people who used ivacaftor were less likely to have bone and joint disease than non-users, and this was the aggregate of osteopenia, osteoporosis, fracture, arthritis. And so in short, ivacaftor is not clearly improving bone health or worsening it. What about ETI? This is FDA approved in 2019. As we've heard in this conference, there is the PROMISE study, which at some of the subsites did include DEXA data, and that data is still coming. There is published in the literature a single center pilot of 9 people with cystic fibrosis that describes changes in bone density, but it's important to note that these patients were only on ETI for 3 months before their follow-up DEXA, and their baseline DEXA was 2 years prior to ETI initiation. Bone is an organ that is undergoing continuous turnover. It is an organ that is slow to respond, and so I feel that this data is too early to actually comment on changes in bone density. So, we're waiting for PROMISE. Now, what about specific anti-osteoporosis medications? So if we recall that people with cystic fibrosis have more bone resorption than formation, so a net bone loss, what if we boosted bone formation? So there are osteoanabolic medications, including parathyroid hormone analogs like teriparatide and abaloparatide, as well as an anti-sclerostin antibody called romosozumab. These medications have been used in people with cystic fibrosis. They are all in case series with 4 or fewer people. They all increased bone mineral density in the patients who used it and seem to have been tolerated. There is no fracture data reported on these as they were very few. And 1 patient did not tolerate the teriparatide, but discontinued very early from nausea, and that's not thought to be actually related to the teriparatide. There is an ongoing observational study for 10 people with cystic fibrosis to receive denosumab for 5 years, recruiting in Texas, and so we look forward to the results of that study as well. What about anti-resorptive medications? So these are going to be medications that are stopping that bone breakdown. And so we've already mentioned bisphosphonates, which are the most commonly used and most commonly studied drug in people with cystic fibrosis. There is an anti-rank ligand antibody called denosumab, which is a very potent medication that inhibits bone resorption. Sorry, this is what the Raksha Jain study is recruiting from. I spoke too early. So we're eagerly awaiting those reports. One caution about denosumab is that if you abruptly discontinue it, you have the risk of rebound osteoporosis with vertebral fractures occurring shortly thereafter. So use it, and if you do, you must have a transition plan. So, in summary, cystic fibrosis bone disease increases the risk for fractures. And primary prevention for CF bone disease is to optimize overall nutritional status and absorption. We're going to aim for adequate intakes of protein, calcium, magnesium, and vitamin C, achieve sufficiency in vitamins D, K, and A, encourage whole foods, limit processed foods, have regular moderate intensity exercise, and also high impact weight-bearing activity as tolerated. Strength training should be in combination with aerobic activity, and as we've all really emphasized, we do this together as part of the care team, and we're not doing this in isolation. All right, should I ask you questions?
Okay. So we can start taking questions. If anyone wants to come up to the mic and ask in person, feel free to. And then I think we can go into some of the questions in the app.
Hi, thanks for the comprehensive talks today. My question is for Sarah. You mentioned that vitamin K2 supplementation has some promise. Can you please expand on that for us?
Not a whole lot. I wish I could provide more. I did not find much as far as, dosing and amounts that might be beneficial from what I've read. The vitamin K2, specifically the MK4 and MK7, have a longer half-life and potentially, better benefit to bone. Beyond that, I did not find a lot of very succinct data, though, unfortunately. You have anything more to add?
Not specific formulas of vitamin K, yeah.
Hi, I think this question's meant for Caroline. I'm wondering if you have any insights as to whether strength tests like hand grip strength, sit-to-stands, things like that can be predictors of bone disease and CF.
Thank you, Maggie, for the question. I didn't find anything super specific in terms of relating direct strength measurements with bone mineral density. I will say the literature out there for specific types of exercise, specific types of testing, and relating that to risk for low bone mineral density or correlation with low bone mineral density are not of the most vigorous study design or quality. So definitely an area that we're looking for some more research in. But I do think it's probably worth noting that if you're doing strength testing in the clinic and you're finding patients are below normative values for their age and gender, that it's reasonable to think that have that trigger a thought, maybe we should be looking at their bone mineral density in addition, because we all know that CFTR is expressed in, skeletal muscle and in bone, and that, a talk earlier today talked about how patients with CF already have strength deficits in compared to the general population as a result of that. So it's reasonable to make the assumption, but I don't have any good data on that for you.
This question is probably for Carolyn. I was wondering, for the recommendation for about 30 to 45 minutes of activity, does that have to be a total duration of 30 minutes of moving weight, or does that include rest periods? And is there a more specific dose-dependent response we see if you consider like reps and sets per week that patients can look for to achieve a response?
Again, I wish we had that data. This was a question we were talking about earlier. There's nothing out there with a lot of specific exercise dosage, like fit, principle, frequency, intensity, time, type of exercise when we're talking about bone mineral density. So what I would say is, I don't know for sure if it's 30 to 45 minutes total working time. I would suspect that it's including some time periods of rest, but it's probably going to be individualized based on the patient, their overall level of activity when you're getting started, what they can tolerate, and how you can build from there. But there's not a lot of good research out there with more specific exercise prescription recommendations.
Small question. Could you, for estimating where a good starting point would be for a patient, would using like a 6-minute walk test be a good way to see if they can achieve a response from moderate intensity activity rather than high intensity?
So I would say if your patient's lung function, if their FEV1 is less than 40, the 6-minute walk test would be a good place to start. If they have higher lung function than that, I would recommend doing something a little bit more intense because the 6-minute walk test is self-paced. So they have the ability to not max it out for us if they're not feeling motivated to participate. So we use the 3-minute step test in our clinic because at least that has a metronome beat and sort of a pace to it that they have to follow. The modified shuttle walk run test is really what I would say would be one of the best field tests to use if you can have the feasibility of doing it in your clinic to determine what intensity to start them at.
Can you please comment about the use of amorphous calcium versus crystalline calcium as calcium supplements and the experience that anyone has in CF patients so far?
Yeah. I'm sorry, I cannot. I really just focused on the two most common ones for this presentation, being calcium carbonate and citrate, since we had such limited time.
These forms are available. They're just hard to get, but they are available out there. They can be plant-based, or blue crab is one of the sources. They're apparently much more bioavailable, and bone mineralization is described as 30-40% higher. So it has a much faster response, and it bypasses the interactions with some of the foods that you described. So that's something to think about in the future.
Interesting. Yes, I will. Thank you.
As a follow-up question for Caroline, Carissa Cully has asked, for patients with advanced lung disease, what are some well-tolerated exercise they can do with a low oxygen requirement and still influence bone mineral density?
So I will say that most of the research I looked at was not looking at patients specifically with advanced lung disease, but in going along with sort of generalizing some of what I found, it's really looking at whatever is the highest intensity exercise that that patient can tolerate. So for a patient with advanced lung disease who is on supplemental oxygen for activity, that might be something as simple as walking on a treadmill at a low speed with a little bit of incline just to sort of get them going. Because the worst thing would be being sedentary, but we also don't want to sort of tip the scales of what they're capable of doing on a daily basis for function. So again, it's going to be using some of your exercise testing principles in clinic to determine what is a safe intensity for them. Usually I would say 25 to 40% if you're using sort of the heart rate reserve max heart rate to determine what type of intensity you want, or that is for those patients, you may be looking at that kind of light MET level, that 3 or below, or maybe the moderate one at 3 to 6, but some of the activities that are a little less difficult.
All right, for Sarah, we've had a number of questions clarifying how to assess calcium intake.
Yeah, I saw a few of those. I was going to start. So when I talked about assessing calcium annually, I'm specifically talking about dietary intake. We don't look at any lab values for calcium. So we're really just sitting down and making sure the patient's getting good sources of calcium on a regular basis, and whether through dairy or other fortified foods, or the green leafy vegetables. And then there was a question while I'm on calcium: does calcium from plant-based or animal matter? And I think the best thing is to get a variety. So some leafy greens and some dairy. So no.
And then as a follow-up calcium question, when supplementing calcium, should you do it with other things, other important nutrients for bone health?
Yeah, so calcium and vitamin D are commonly, put together for improved absorption. I think that's a good one to do. And, try to take it with other foods that will help you absorb those too. Yeah.
So Caitlin Violante has a question. If there's no endocrinologist available in our care center who takes ownership of treating osteoporosis, should we refer to an endocrinologist or defer back to the PCP? I would love to say you should defer back to the PCP, but as has been hammered home during this conference, our patients consider the CF center their PCP, and many do not have a PCP. So that's not necessarily a viable answer. In pediatrics, the general pediatrician will probably, almost certainly, not be comfortable managing osteoporosis. And while endocrinologists are most common, I think, of the specialties who do, you should check with your center who is the specialty who does manage osteoporosis. It may be nephrology, rheumatology, genetics, and there is one center I know of where gastroenterology does it, and I'm not quite sure why. For adults, though, many family practice doctors and internists do have some comfort in managing osteoporosis, so they may be a viable solution. But again, I would say, find out at your center who manages adult osteoporosis when making that referral. All right. Heidi, recommended exercise dose.
So I see a question here that says, is there an expected rate and amount of bone mineral attenuation you might expect for postmenopausal women who apply the recommended exercise dose? And I do not know the answer to that. If you can find it out there in the literature, though, send it to me.
I will also emphasize that for postmenopausal women in the first 10 years after menopause, we do recommend hormone replacement therapy with estrogen. This is, again, hammered home during this conference, not a contraindication for people with cystic fibrosis to receive estrogen postmenopausally, and that would help attenuate that a little bit. Depends. All right. Should I answer this?
I can read it if you want to answer it. We can give it a go. There's a question here, as we sit here debating on the microphone, right? For a teenage male with bone mineral density Z-score already at less than -2 with interventions in place, how much can it improve? Patient has CFRD, kidney stones, G-tube, short stature, previous growth hormone treatment, and an FEV1 in the 70s.
So I think this really depends on what interventions this person is referencing to. Like, are we already optimizing physical activity, and are we already optimizing nutrition? Have we optimized dysglycemia, hyperglycemia in the cystic fibrosis related diabetes? This patient, although the FEV1 is in the 70s, does not sound the most healthy. And so has there been an assessment for pubertal status, or are they even in the age in which puberty should be considered, because it just says teenager. And I think the other thing that we should be asking is, do they have any evidence of skeletal fragility? Have they had fractures? If they have had fractures, what did they fracture and with what mechanism? If the answer is that they've had fragility fractures, then one should consider if they would benefit from specific anti-osteoporosis treatment. If this did not satisfactorily answer your question, I'd be happy to discuss with you in more detail, whoever asked that, after.
I think that's all of them.
All right. Thanks so much, everybody.
Thank you very much.